By listening to this podcast, you agree to not use this podcast as medical advice to treat any medical condition in yourself or others, including, but not limited to, patients that you are treating. Consult your own physician for any medical issues that you may be having. This entire disclaimer also applies to any guests or contributors to the podcast. Under no circumstances shall any guests or contributors to the podcast or any employees, associates, or affiliates of the Neuroendocrine Cancer Awareness Network be responsible for damages arising from use of this podcast. Welcome, everybody, to another episode of Let's Get Real with NCAN. I am Mike Wayman, your host. Before we get started, I do want to remind everybody that we do have another patient conference coming up on April 15th. We will be in Omaha, Nebraska. If you want more information on that, please head over to netcancerawareness.org or hit us up on social media at netcancerawareness. Today we have the medical oncologist from the University of Iowa. We have Dr. Chandrikha Chandrasekharan. So welcome to the show.
Hi, Mike. Good to see you
see you too.
Virtually again.
Yeah. Well, we met at what was it? The
GI ASCO, I think, in person.
Okay. Yeah. And were you at the Atlanta conference?
No, I haven't been to NCAN conference. We had one in Iowa in 2017 or 2018. I think
Yes.
That's probably the one that I attended, but not.
Okay.
Yeah.
Yeah, that was the one in Iowa where actually my buddy Jimmy and I, who we were running the AV, but we were running around to different offices to see if they were open to try and pull chairs in, because you guys had a huge audience there. Huge audience. We were not expecting it.
So hope to again have one more later in sometime in the next year or so. Yeah.
Yeah, absolutely. So let's just get into this real quick. Tell us a little bit about yourself and your practice and where you're from.
Sure. I will probably start by pronouncing my name like most people start out, like, how do we say your name? So
Yes.
I usually go by Chandrikha. That's my first name, Chandrikha Chandrasekharan. So I'm actually a medical oncologist by training. I've been at University of Iowa as a neuroendocrine tumor specialist now from 2017. I'm trained in also palliative care, and I did an advanced year of oncology, GI oncology, gastrointestinal oncology specifically. So I did not honestly set out to be a neuroendocrine specialist. I think it just kind of happened over time. And I'm glad the way my career shaped out and the interest that I have currently. So I, after oncology fellowship, I went to Mayo for a GI oncology fellowship where I worked with Dr. Heftinerson, who a lot of patients probably know. Mm-hmm. And at Mayo there, we had a large volume of patients with neuroendocrine tumors. So it's kind of like suddenly going from a fellowship program where I barely saw 2 patients with this cancer a year to 2 patients with this cancer every week. I think, it was just kind of a transfer. It was natural attraction towards neuroendocrine tumors. And then I think things again happened from there. And I got a job at Iowa where, of course, I was known for Dr. Orizio, Dr. Dillon, Dr. Howe, and a whole big team with neuroendocrine tumor expertise. And so Absolutely. It's been perfect landing. So kind of, yeah.
Yeah, absolutely. Absolutely. So obviously that's what led you to become a NET specialist. So why do you think it's important for patients to be involved in their treatment plan?
It's a different cancer than others in many ways. I'm sure every patient with the cancer diagnosis has their own journey and their own, how they feel and how they navigate this. But, and again, I can't speak from a patient perspective, obviously, but, it's different. As a GI oncologist, I actually take care of patients also with other cancers beyond neuroendocrine tumors. So I take care of patients with colon cancer, pancreas cancer, and the needs are very different. The journey is very different, of course. Have to live with this cancer a long time also comes with a different kind of burden. It's many symptoms. There are symptoms that are not well characterized. and a different amount of caregiving that comes with it, a different amount of coordination that comes with it. And then as many patients, as many people in the audience probably relate to, just having even a lot of medical community people like not recognize this as a cancer sometimes, or not recognize all that comes with this cancer, which is different, right? So I think
Sure.
this makes it different, and different and difficult maybe, in many ways. So as a medical professional, having the expertise with the team that is devoted to it makes a difference. I think we can't minimize the importance of a multidisciplinary team, like more than one brilliant mind involved in neuroendocrine tumors working together, because there are so many aspects of care in this cancer. And in many cancers, many times it's very prescriptive, like an oncologist kind of doing the big chunk sometimes if there's no surgery involved. But this is still in a patient with an advanced neuroendocrine tumor. It's not just the oncologist, so many people that are necessary as part of the team.
Yeah.
So a lot of that makes it different, from even a medical professional aspect, I think.
Sure. Now, with regards to getting proper care, what do you think? And I think this is going to lead into your presentation a bit. But what do you think is the most important decision a net patient can make?
I think for the patient, first of all, in any cancer, and including neuroendocrine tumor, to have a team on their side, and a team that listens to them, and a team that communicates with them very well is very important. I think what should the team comprise of, or who should the team comprise of, is the next question. I think the thing that I want to discuss is whether a high volume center for care is necessary, a multidisciplinary tumor is necessary, a team is necessary or not for this particular cancer. So kind of going along with the theme, I think the team should definitely, for a patient with neuroendocrine tumor, comprise of more than just one specialty. I think at least have access to different specialties like radiology, nuclear medicine, endocrinology when necessary, and many times it's necessary, or surgical oncologist. So I think from a patient perspective, seeking such a team that's communicative, that's able to listen to the patient's needs and symptoms, and and works together. And not to minimize, it's not possible for every patient to travel 5 hours, 2 hours to get to a center. So there's always a necessary, local team as well. So then this complexity of coordinating with the local team in a center of excellence or a high volume team comes up. So I think that's also important, that those medical teams communicate with each other and with the patient.
Yes.
Communication is very key, I think, in this journey. And it has to be both ways. And it still definitely has to be, ultimately, the patient should be the one who feels comfortable with that and confident of the team.
Absolutely. So, as we alluded to, she's going to talk to us about the importance of multidisciplinary teams. So, without further ado, Dr. Chandrikha, we are going to give you the floor.
Yep. So I'm not going to make a big presentation. I think, a few of the things that I noticed for patient care is, like I said, this cancer involves so many different aspects of care. So somebody who's diagnosed, for example, kind of walking through maybe the first few steps of, when you're diagnosed. Okay, you've been told you have a cancer that's neuroendocrine tumor, and then sometimes maybe you're told, oh, well, I only see one of this, once a year, so I don't know much about it. So that could be a very common situation a patient then finds themselves in. And, sometimes the patient has to do the research. Sometimes, hopefully, the medical team does the research on behalf of the patient to figure out what are the next steps. And again, every individual patient is so different in their presentation of the cancer, the symptom burden, everything. So, for something like, say, a pancreas cancer and adenocarcinoma, which is like the regular pancreas cancer we talk about, things are a little bit more structured in practice. So if you're diagnosed with, let's say, a stage 4 pancreas adenocarcinoma or cancer, then, you have a couple of options for chemotherapy. You look for a clinical trial. And then if there's no clinical trial, you go on to one of these chemotherapies. And that's kind of how the journey unfolds. But let's take a patient who was diagnosed with a pancreatic neuroendocrine tumor. Now, starting with just, okay, the pathology. I think the first key thing, having a great pathologist who knows the nuances of diagnosis is very important. And sometimes, we still get patients that are diagnosed and we revise the pathology, meaning we look at it and we're like, oh, no, this is not a high-grade neuroendocrine tumor or a small cell neuroendocrine carcinoma, as it's called, which is like different types of, I guess, the aggressiveness of cancer. And then our pathologist reads it and says, oh, this is probably more like, grade 3 well-differentiated neuroendocrine tumor. So then again, the management of that patient changes based on this. So right from that level, I think we start seeking net expertise on top of just cancer expertise, because there are these nuances. And then again comes the radiology bit. So once you get a diagnosis, you're getting a scan. Often these days, we are getting a copper scan or a gallium scan specific to neuroendocrine tumor. But how does that scan get read or interpreted matters, or how the scan gets done actually matters. Because, for example, a CT scan, which is often done as at the time of diagnosis, has to be done with IV contrast, like the dye that they give you to look at the cancer better. Now, neuroendocrine tumors are known to be finicky in that sense. They really show up well when the contrast or the dye is injected at a certain time and in a certain way. So sometimes if the contrast or the dye is not injected in a good timing, you don't quite see all the cancer very well. So even at that stage, even at that time, then there's again a need for something that's special to neuroendocrine tumors, like a radiology technique that's special for neuroendocrine cancers, or a radiologist who reads this with a little bit more expertise so they know this cancer looks like this and presents like this. So right from that beginning stage, it's a little different when you're talking about neuroendocrine tumors compared to maybe some other cancers. And then comes the question of, okay, what do we do about this situation? Well, and I'm again talking mostly about a patient, let's say, who's presenting with a cancer that's already spread. If it's not spread, of course, the question of surgery and where to do the surgery comes up right away. But even in a patient that has cancer that's spread to like the liver or another organ, oftentimes, in a stage 4 cancer of other kinds, you routinely just start out with the medical therapy or medication or, chemotherapy, depending on the cancer. But again, if it's neuroendocrine tumor, it's different. Even if it is stage 4 cancer, even if it has spread to your liver or other organs, we still think about surgery as an option. And again, that makes it different from another cancer. So then the patient's next question sometimes is, or the medical team's next question is, where do we go from here? And again, a high volume surgical center probably is something that most patients would seek out or should seek out. Now, while we're talking about this high volume situation, so how did this high volume concept come of? What is high volume concept, or how do we know which center is high volume, or which center should we seek for our care? Now, some of this historically, the background comes from surgery. When cancer surgeries were being performed, they looked at some standards and associated them with outcomes. And there were multiple papers published over the years, for example, esophageal cancer surgery or pancreas cancer surgery, looking at a particular center that did so many procedures per year. And again, there's not perfect cutoffs of what's considered high volume. It depends on the type of surgery. It could be different for a joint replacement. For a cancer surgery, it could be a different number. But clearly what was seen was when patients went to surgical centers that did a lot of the procedures, a lot more of the procedures, kind of like, the expertise comes with it. When you do more, you see more, you get more complications, you know how to manage them better. So that's how this concept of high volume centers came about, mainly from surgical literature, I would say. And clearly it seemed to favor patients who went to that high volume surgery centers for their cancer surgeries, or even, like I said, joint replacements and other things. They had better outcomes, less infections, less complications. Now, applying the same concept to neuroendocrine tumors, it's not just about surgery. I wanted to point out this one. There's not much literature or much evidence published about, one, what defines a high volume center, or how do you classify that, and how to look at the difference. So when I looked up literature myself or evidence published, there was one paper that I'm presenting here with the curves. I can explain what they did. So this group looked at what we call SEER database. SEER is like, National Cancer Institute run registry where they collect information from 22 states in the country about their surveillance, their epidemiology, their outcomes of different types of cancer. And then they looked at Medicare claims. So Medicare obviously means 65 and above. And they tried to match up the data of the type of treatment and then the center they got their treatment for specifically neuroendocrine tumors. And then they kind of made, based on the statistics, some distinctions of what we would call low volume centers, high volume centers, or medium volume centers. So the three curves that you're seeing here in blue is the low volume center. So a low volume center in this particular study was defined as when if somebody saw less than 4 patients, new patients of neuroendocrine tumor, or 4 neuroendocrine tumor patients in the past 2 years. And a medium volume was anywhere between 5 to 14 patients in the preceding 2 years. And a high volume center was if they saw more than 15 patients with with neuroendocrine tumors. So that was the cutoff based on the study that they looked at. And they looked at disease-specific survival, meaning like neuroendocrine tumor-specific survival. As you can see in this curve, what it shows is those patients that went to a high volume center, that is in this green curve, seem to have a better survival specific to neuroendocrine tumors, and those that went to a low volume center here had maybe less survival. Now, if I just look at this data without dissecting the details, it's like, oh, obviously go to the high volume center is the answer. But there are a lot of things to look into, of course, the study, because people who had what we would call a high grade neuroendocrine tumor, meaning like a more aggressive variety of neuroendocrine cancer, they tended to be more likely to at a low volume center and less likely at a high volume or an academic or NCI designated cancer center. So some of this could also be due to the fact that people who stayed local were actually sicker or had more aggressive disease, even though they adjusted for these factors. So the authors that published the study adjusted for these factors. And despite that, there seemed to be a difference that patients who went to a high volume center seemed to have a better outcome. Again, this particular study was the only study like it's published in neuroendocrine literature where they, again, arbitrarily defined the center as more than 15 new patients in the past 2 years, or 15 patients taken care of by the center in the past 2 years. So, this brings up the question, should every patient always go to a high volume center? Is that what is necessary? We can talk all about it, but I think practically it's not possible. And again, you can't just go to, you may not have access, you may not have transportation. There could be so many factors. You may not get an appointment on time once you're diagnosed, for that matter. So there are so many other factors that could actually come in the way. But I think there is definitely value in a rare cancer to go to an academic center or having an NCI designated or more comprehensive neuroendocrine tumor team involved in your care. Again, how that's defined is still unclear. Who gives that stamp of approval is unclear or not defined. But I think there's value because when you go to an academic center or an NCI designated cancer center or a high volume center, whichever way we define them, the minimum requisite or the expectation is in that particular center, they're going to have more than one specialty focused on neuroendocrine tumors. That could involve, again, it could be a team led by one specialty, but there has to be a backup, like I said, of pathologists, surgeons, neuroendocrine oncologists, endocrinologists, radiologists that are somewhat, involved in neuroendocrine tumor and know about the cancer and know about the difference, that is, the differences and the nuances of treatment that's different from other cancers. So another concept that I want to talk about along this high volume center, for example, another thing that patients may hear about is this certification or center of excellence. Center of excellence, just to kind of make people familiarize you with the concept. It's a certification that the European Neuroendocrine Tumor Society gives out to certain centers that meet some basic criteria requirements. For example, there are multiple centers of excellence in Europe. Outside of Europe, there are two centers of excellence, I believe, in Australia. One is Peter MacCallum and another one in Sydney. And outside of that, in the US, I take pride in saying that University of Iowa is the only center, ENITS Center of Excellence for Neuroendocrine Tumors. Now, in order to get a center of excellence by ENITS, that particular cancer center or neuroendocrine tumor center has to meet certain criteria. For example, they have to see at least 80 new patients with gastroenteropancreatic neuroendocrine tumor. So gastroenteropancreatic means patients who have neuroendocrine tumors in the gut, anywhere along the gut, stomach, colon, rectum, small bowel, pancreas, everywhere. There's also some stipulations or criteria for lung. At least 20 new lung neuroendocrine tumor patients have to be seen by the center. And then they have to have definitely what we call a tumor board. Tumor board is where often we present patients with this cancer, not just neuroendocrine tumor, but it's a concept in any cancer. Either it could be all new patients or patients where we have to make a decision on the next steps of treatment. What do we do next? Should we do the surgery? Should we do embolization? Should we do this? Or should we give them chemotherapy or should we give them PRT? So there should be a neuroendocrine tumor board or a tumor board where definitely a neuroendocrine tumor patients with neuroendocrine tumor are presented and discussed. And again, there are also criteria for what should, who should be in the tumor board. There has to be a required pathologist who has expertise, some expertise and a certain volume on neuroendocrine tumors. There has to be an internist with neuroendocrine expertise. So that could be an endocrinologist or a medical oncologist who has a fair amount of experience in neuroendocrine tumor management. And there has to be a surgeon, a radiologist, and then endocrine, like I said, I already mentioned endocrine, a nuclear medicine doctor or a radiologist who's experienced in neuroendocrine nuclear medicine. And if necessary for a lung, we have to have a pulmonologist or thoracic surgeon who's experienced and has some volume in patients, taking care of patients with this neuroendocrine tumor. So these are prerequisites that have to be met. Any center actually can apply to ENETS for a center of excellence. They have a rigorous process of auditing where they actually have people come and review the volume, go through the tumor board, look at the notes. There has to be documentation of how the patients are discussed and how it's documented. There also has to be patient participation. Do they get consent from the patients? Are there research activities going on? Are there clinical trials being conducted, like new therapies, new advances being conducted that are, beneficial to the patient? So all these elements have to be met. And then it's not like a one-time stamp and certification. You get it. You can't be complacent and be, just going on with it. They also do auditing. So they have certain intervals. They come back and audit again to see if, again, these elements are met. So this is another way to identify possibly with definitely a high volume center, because if you're seeing 80 new patients per year, you are a high volume center by any definition. Now, of course, there's a lot of controversies whether you need that stamp of approval by Center of Excellence approval or not. Again, I'm saying controversies within the medical community whether that stamp of approval is necessary, because we know for a fact there are definitely many centers in the country, in the U.S., where they have all the team members, they have all the necessary volume as well, but they just don't have the stamp of ENET Center of Excellence, because it involves like anything in administration, medical world, involves like a lot of effort and sometimes money to put together all of this. But I think this is one way to identify, but outside of that, it's a little hard to identify for a patient, like to look at, the website or look at something and say how many patients did they see with my particular type of cancer. Now, in some surgeries, for example, like esophageal cancer surgeries or pancreas cancer surgeries, many centers and many hospitals are actually required to publish that data or, have it available in some form for the patient, so the patient can make a determination of, this hospital that I'm going to has done at least 20 Whipple surgeries in the past year, and that's in many standards considered as a high volume center for pancreas surgeries. So this is a good place for me to get my surgery. versus like a center where they've done just 1 or 2 surgeries. And the same thing with colorectal surgeries and things. So these are some ways to identify, again, like I said, the criteria, there's not a lot of agreement on what's high volume, how to identify high volume, how to, certify high volume or advertise high volume. But I think it is important from a patient perspective, like I said, to seek a team approach and a team approach with communication. That's very, very key. And again, we're not talking about, like a one-time visit. We're talking about years of care, years of managing, patients. It's almost like, it's like, I hope I'm not overstepping the boundaries by saying like it's sometimes like some of our patients are like our family. I think I sometimes see our patients more often than I see my family back in India. So it feels like you have to have that communication, you have to have that rapport, you have to have that confidence, and you have to have that team behind the scenes sometimes, but there is definitely a team. And I think it's important to seek the team, whether it's because of these data that says, like I said, high volume centers, maybe make a difference in the outcomes. But again, I don't want to make sure, I want to make sure we don't take all the credit as high volume center there. We work in conjunction with the team in the community because that's what is accessible to the patient. That's what is near your back door. You don't have to get a standard injection in a high volume center because it's administered the same way. But if the cancer is growing or there's some kind of a change, then you want the expertise, then you want the team approach, then you want that multidisciplinary team looking at this and then saying, oh, well, this could be one approach, this could be another approach. And sometimes, again, or many times, we also need the input of the patient as to how they feel about a certain way, a certain treatment.
No, the importance of a multidisciplinary team is super, super important, and that's something that we stress a lot at our conferences, at this podcast. Also, seeing a specialist, having a specialist involved in your treatment plan is paramount. It's very, very important.
Yeah, but I think one of the things that I've heard some patients say is how, is it okay to ask the physician that you're seeing how many patients of this kind do they see? I think sometimes patients hesitate to ask the question, not to offend the physician maybe or the medical team or things like that. But, it's, I would think of it, I don't want to, again, minimize or give an analogy that's totally inappropriate. But I think if you're going to buy something, you do so much research about buying something. You look at, so many factors. So it's okay if you're talking about your health, you're talking about a cancer. And I would probably say if a physician gets offended by the question, that would actually raise a red flag, because
For sure.
if someone asks me how many of X cancer that I see, and if I don't see that cancer, then I'm going to have to be honest with the patient and say, no, I don't actually see that many of this kind.
Yeah.
And I think that doesn't mean I'm not going to take care of that patient, or that doesn't mean I'm not going to invest time and energy to learn about it. It just tells them, well, maybe they can seek a patient or a team that has seen more of that and work with the local specialist.
Right.
It's okay to ask the question, at least in my opinion. I would hope they never shrug that question off ever if a patient asks me the question and give an honest reply, because, if you don't ask, you don't know the answer, so it's okay to ask the question. I think it's also okay to get a sense of who else is involved. Like I said, a lot of times the other experts in this multidisciplinary team are behind the scenes. I don't think a patient ever comes face to face with a pathologist or radiologist, but they are such important members of this team. And, obviously you don't have a way to know, how many neuroendocrine tumor pathology reads to that person do, right?
Sure.
So I think that's a very key element I stress upon, because, that's where a medical oncologist or a person starts treatment decisions.
Yeah.
So these are questions I think the patients have a right to ask, have a right to know, and it's okay to ask. Again, this is, just to be sure you're getting what you need, basically.
Yeah. I do think that, and that's another thing that us as a patient advocacy group definitely likes to put out there is that you shouldn't be afraid to ask questions. You shouldn't be afraid to ask your doctor questions, because you're on this team too. It's ultimately the decision is yours, but it's a collaborative effort.
And sometimes even the multidisciplinary tumor boards or the high volume centers or whatever we call as, they may, we don't have all answers to every problem or every situation either, right? So we have to recognize that, medicine is an art, especially cancer treatment, especially neuroendocrine tumor is an art. Some of this definitely comes with experience. I definitely could not have said this 2017 when I first started out, in this world, in this field. I think some of this, and I still learn every single day. I see a different approach taken by a different person. I always question why and how does that make sense? And again, the same thing with patients too. I think patients give a lot of input. Their fear about the treatment options, or their worry about their quality of life. Their worry about what this means to their life and living. I think these are elements that, there's hard to capture that in a study. It's hard to capture that in a paper or publish. But I think these are very important elements that have to be incorporated in that team approach. So when I talk about a multidisciplinary team approach, front and center is the patient, caregiver, and everybody in the journey, right? So everything has to still revolve around them.
Absolutely.
And the others are, like the satellites roaming around the sun, kind of. Yeah.
That makes a lot of sense. That does make a lot of sense. That's very great. That's great. Well, thank you so much for presenting to us this information. Again, see a multidisciplinary team. Ask the questions. Don't be afraid to ask the questions if you want to know. And like Dr. C said, if you have a doctor who's uncomfortable with you asking those questions, maybe that's a red flag. That's definitely something you should look at. But don't be afraid to ask the questions. And thank you so much for sharing this information with us. Once again, I want to remind everybody that April 15th, we do have our Nebraska conference from the University of Iowa. We do have Dr. Dillon and Dr. Howe presenting. So that'll be great. They're mainstays here with NCAN, and hopefully we can get you out to a conference soon.
Look forward to it. Thank you so much. Yeah,
absolutely. So everybody, if you want more information, please go to netcancerawareness.org and also go to @netcanceraware for all of our social media stuff. If you enjoy this stuff, if you enjoy this type of content, please make sure you subscribe. It helps us beat the algorithm, and it helps us get this information out because it's so important to get out there. Once again, thank you for joining us, and we'll see you next time on Let's Get Real.
Thank you. Thanks, Mike. Thanks, everybody. Yeah.